I would like to welcome you to tonight's virtual program, Optimizing Vascular and Skin Treatment with the Nordlys platform, with Professor Firas Al-Niaimi and Professor Peter Bjerring. If you have questions during today's event, please enter them in the Q&A box. We will answer them at the end of the event. If you encounter any issues with the video connection, please refresh your browser, as that will often fix minor issues. Google Chrome is the preferred browser. The information and photographs contained in this presentation are the property of Candela and its consulting healthcare providers, and are provided for global training, educational and discussion purposes only. Candela Corporation and its affiliates make no representations regarding federal, state, local laws or regulations that might apply to use and operation of these devices. For this reason, please review your country's current indications for use as provided by the respective regulatory agency. By sharing this information, neither Candela nor any of its consulting physicians give you the right to use the information presented, and this content is not intended to be a substitute for professional medical advice, diagnosis, or treatment. Treatment considerations are under the discretion of the qualified licensed healthcare professionals. Individual healing times, discomfort, treatment results, and satisfaction can vary. By participating in this webinar, you agree not to photograph, reproduce, or distribute any of the information or photographs presented during the webinar. With that, I am very pleased to introduce our moderator for this event, Professor Firas Al-Niaimi, who is a renowned dermatologist with over 210 publications and 400 global presentations. With more than 20 years of expertise, he trained at top UK hospitals and became the UK's first professor of laser dermatology. Professor Firas, the floor is yours.
Thank you very much, Aviva, for the kind introduction, and good evening, dear colleagues. This is going to be a fantastic webinar today. Just before I introduce the next speaker, Professor Bjerring, I just want to mention that if you can ask the questions at the end of the webinar, because we will have ample time for questions and answers. Right, it gives me immense pleasure and honor to introduce my colleague, Professor Peter Bjerring, who is a friend, colleague, a mentor, and a teacher for me, and is actually a colleague of mine also at the University of Aalborg in Denmark, where I also work. Professor Bjerring has many, many years of experience in lasers and in dermatology, with more than 250 scientific publications, 500 international presentations in many countries. I always enjoy talking to Professor Bjerring because he's a physicist, an engineer, and a laser dermatologist. So he can explain to me also about the physics of lasers and IPL. He has won many, many awards and prizes, and he was also the past president of the European Society of Laser and Dermatology, which I will encourage you all to become members of. And he's also a fellow at the EADV and a regular speaker at the American Academy of Dermatology, where he an honor prize for his services to laser dermatology. So, Professor Peter Bjerring, I will hand over to you.
Thank you very much for this very kind introduction. I think this presentation actually will be yours for the first part of it. Okay. So I think you should move on here.
Yeah, I can see that now. We're doing it slightly differently because yes. I'm going to start first with the non-ablative laser, the 5050 and the 1940, and then we'll finish off with the IPL handpieces, yes. And that is on purpose because vascular treatments is something that is very common, and there are going to be many questions about vascular lasers. So I'm going to start first with the two non-ablative fractional handpieces, the 1550 and the 1940, that you have in the Nordlys platform. For those who are not familiar with the Nordlys platform, it's a platform where you can have multiple handpieces attached to it. So Professor Bjerring is going to talk about the IPL handpieces. We are not going to cover the NDAG handpiece, which is also one of the handpieces that you can have attached to the Nordlys platform, but I'm going to cover these two non-ablative fractional handpieces. So why do we have two different non-ablative fractional handpieces? This might be a common question as to what if they are both fractional and non-ablative, does it make sense to have two different wavelengths? And the answer is absolutely. And that is because these two different wavelengths, although both of them will have water as their main chromophore, the affinity to water is different, and therefore the tissue interaction and the level of biological interaction in the skin is going to be completely different. So if we start with the 1550, that is a wavelength with relative strong water absorption, but less strong compared to the 1940, which means that it's going to reach the deeper layer of the skin in the dermis, and this is what we were going to be using if we're dealing with scars, acne scars, wrinkles, rejuvenation. On the other hand, the 1940 as a wavelength is very close to the 2000 nanometer, and therefore its effect is much more superficial because of the strong water absorption. For those of you who are not familiar with fractional laser essentially is fractionating the beam of light, where we then have these columns of coagulation, so we can then decide how deep or superficial we want to go. So as I mentioned earlier, with the 1550, we can reach deeper layers of the skin, whereas with the 1940, we're predominantly in the epidermis and in the papillary dermis. Okay, so this is, again, just if you look at the blue graph on the right-hand side, you can see that's the water absorption curve, and you can see on the far right where it's purple, that's the 1940, and you can see it has a higher water absorption compared to the 1550 to the left, which is the blue, and this explains why the tissue interaction is different. So with the 1940, the effect is more superficial. With the 1550, the effect is deeper, and this can be illustrated very nicely here with this histology slide. And these are histology slides from Candela. If you look at on the right-hand side with the 1940, you can see the coagulation zone, very much superficial. You can see that predominantly in the epidermis and a bit in the papillary dermis, but you can see this almost microscopic clefting in the epidermis. So that's the level of impact or biological interaction in the skin. On the left-hand side, if we look at the 1550, you can clearly see that we have a much deeper and narrower column of coagulation extending deep into the dermis. Now, that depth will also depend on the fluids. So the higher the fluids with this wavelength, the deeper you are going to go. Because again, this is one of the common questions colleagues will ask and say, well, if I have a deep scar, will it reach there? Well, in that case, obviously, your fluids will going to be higher. So these two images of histology are a powerful illustration of the level of tissue interaction. On the right-hand side, that's the 1940, predominantly superficial, and on the left side, that's 1550, and that is deep. So once again, it is illustrated here. I would like to say one important point that sometimes colleagues ask and say, can I use the 1550 with low fluence and I will be more superficial? It doesn't work that way, because even with the lowest fluence, you're still very much in the mid-dermis. And even with the highest fluence of the 1940, you're still very much in the papillaries. So they are going to work differently. So why does it make sense to have both wavelengths and sometimes even combine them in one single treatment? You can see that with the 1940, we are predominantly having an effect on the epidermis. So it's more of an epidermal resurfacing, but without the downtime of ablative procedures. So tone, texture, epidermal pigment. And if you look at the 1550, that's predominantly having an effect in the dermis, scars, striae, and pores. But what is also unique about this handpiece is the ability of the scanner to adjust the scanning width. Okay, so you can see that we can choose a very narrow scanner width from 4 millimeter or all the way up to 12 millimeter. And this means we can customize the treatment. If you can just imagine you have a surgical scar and you would like to just focus the treatment on the surgical scar, a linear surgical scar, we can then use the 4 millimeter. It will be much more effective on that linear scar. On the other hand, if we're treating a décolleté or a cheek, we can then use a 10 or a 12 millimeter spot. You can also see from the dots, which represent columns of coagulation, that with the narrower scanner width, the density is higher. These coagulation columns are coming closer together, so it's more impactful. Whereas with the wider scanner width, they're further apart and the density is lower, which also means that if we are having a higher skin type and we want to reduce the risk of post-inflammatory hyperpigmentation, which is often associated with the density, we can choose a wider scanner width. So this really is a very helpful tool which will allow us to customize the treatments. Okay. Right, so here, this is just an illustration of how the scanner works. I hope you can see that in the video. Essentially, it is very easy. You just hold the handpiece as you move the handpiece there. So the scanner is within the handpiece. So this is just an image of the interface where you can see we can choose the fluence, and that will tell us on how deep we are. So it does guide you in terms of the estimated depth. And we can choose also the density. So 30%, that's a density that we can choose. But if you want to do a milder treatment with lower density, we can decrease that. Or if you're working on a small area where you want to have more impact, you have the ability to increase the density. And you can see on the left, we can choose the scanner width. All you need to do is just click on that icon, and that will then change the scanner width. So here are just some examples. If we look at the non-ablative fractional laser 1550, and in this case, as I mentioned, we are going to target scars, and acne scars is one of the conditions that I commonly see. Now, of course, I have to mention that the treatment is often a combination treatment where you may require procedures such as subcision, punch excision, TCA cross. We can discuss that later in the Q&A. But from the laser point of view, we are going to use the non-ablative fractional laser. And what I like is here I can customize where I can, for some of the deep scars, choose maybe the 4 or the 6 millimeter scanner width, do a few passes where I ensure I have enough coagulation at the base of these scars, and then I can choose a lower density with a 12 millimeter to treat the background. So other examples of scars that you don't necessarily always need to have fractional ablative laser. You can also get these nice results with series of non-ablative fractional lasers, such as the 1550. Here you can see dilated pores and some nice tightening of pores using the non-ablative fractional laser 1550. Some other examples of surgical scars. If you look on the right-hand side, that small scar, this is a perfect example where you can just use the 4 millimeter and you can focus the treatment on the scar, sparing the surrounding area. And this is what I mean by customizing the treatment. In this unfortunate young girl with a traumatic scar, where you can see there is visibly also a vascular component. So in this case, this is where it gets more interesting, and also the benefits of having Nordlys as a platform with multiple handpieces, because we can address the vascular component, and I'm sure my colleague Professor Bjerring is also going to talk about that, by using the PR handpiece in this case, given her lighter skin complexion, using that to treat the vascular component. And then immediately afterwards can use the non-ablative fractional laser 1550. Some would like to start first with the vascular and perhaps at a later stage treat with the non-ablative. That is fine, but we have enough data and experience that we can combine these two treatments in the same setting. So that's PR handpiece first, addressing the vascular component of the scar, followed by non-ablative fractional laser 1550. If you look at the scar, this patient who had traumatic scars on the cheek, this is just more thicker and elevated. That's obviously where you're going to be using higher fluence to get deeper. And in the more shallower, flatter scars, lower fluence, but with just that skill of adjusting the fluence and the density. And here is a close-up view. You can see that there's very nice improvement and resolution of these scars, which is also important to her, because the first thing she said to me, well, you know, I like to cover my scars. I need to put foundation and makeup. If it's going to crust and ooze, I don't want the treatment, which already basically means that she is not keen on ablative laser treatment, and therefore the non-ablative fractional. Another example of some traumatic scars, and this is where I really like the ability to be able to choose a narrow scanner width of 4 millimeter, because I tell the patient, here we can customize the treatment. Again, you can use a pulse dye laser or an Nd:YAG, or just the PR handpiece first, or the VL handpiece for the vascular components of the scar, followed immediately by the non-ablative fractional laser. Here another surgical scar, it's a small scar. This is where you will use the 4 or the 6 millimeter 1550, just targeting the scar, and you can see very nice improvement there. This is another example where you will combine both handpieces. So that's going to be the vascular handpiece, the PR or the VL handpiece with the vascular mode, which Professor Bjerring is going to talk about, followed by the non-ablative fractional laser 1550 handpiece, and you can see nice clearance. And the advantage of doing the combination is we are going to improve on the scar, but at the same time also reduce the vascularity. Barcode lines is one of the things where I still think that if the patient is willing to have the downtime, that ablative resurfacing still gives better results. That is my opinion and experience. However, there are many patients who are not keen on that. And here, this is an example where just with a couple of treatments using the 1550 wavelength, there is certainly definitely an improvement here. And again, we can combine these treatments with sometimes injectable. I like to use a 4 or a 6 millimeter scanner with first doing 2 to 4 passes of the scar, and then I will do a 12 millimeter scanner with low density, treating the entire cheek. And you can see here also on the other side. So that is using the narrow scanner width on the individual scars, followed by a wider scanner width treating the background area. This is how I address scars. Okay, that's her again. Right, what I wanted to illustrate here is that the Nordlys is the only non-ablative fraction laser that allows us really on the expert mode to be able to change the pulse duration. So you can see here, we have a pulse duration of 2.7 milliseconds. And then if we look at the estimated width of the coagulation column, we can see that's 370 micron, because the pulse duration will also dictate the width of the coagulation column. But when you go on the expert mode, you can actually choose a short pulse duration as short as 1 millisecond, which will narrow the coagulation column to 270 micron. So it is really narrow. So with a higher skin type, this is what I do to reduce the risk of post-inflammatory hyperpigmentation. I go on the expert mode, I choose short pulse duration, low density, cool in between, and you can do still your few extra passes, but you have lower of higher Fitzpatrick skin type. Perfect scar, where you almost want to have an ablative effect of coagulation. You can go for a very long pulse duration, which will give a very wide coagulation column, and then with few passes, you get much more heat and you get much more of a tightening effect. Really the selling. That's why I choose this like wide coagulation. Other example of acne scars, in this case, she's a light skin type, small scanner width, high density on the individual scars, and then just use a wide scanner width on the background skin, and you can see very nice improvement. Where I will choose the short pulse duration on the expert mode, 4 to 6 millimeter with low density, but doing few extra passes on the individual scars, followed by a 12 millimeter scanner width everywhere, and you can see there is no post-inflammatory hyperpigmentation and good clearance. And that is simply just the physics of playing with the pulse duration. Another example here where we combine the a vascular handpiece with a non-ablative fractional handpiece, another combination here for scars. Another example where it's nice to use just a 4mm scanner width on the individual scars here. A scar on the knee, again, using the non-ablative fractional laser here. And one of the other things that you can also do is lip rejuvenation with the 1550 non-ablative fractional laser. And that gives some plumping, neocollagenesis, but also neovascularization. So particularly in the more mature women where the lips are not just thin, but more white and lost that pinkness of the color, some series of the 1550 can work very well. This is just a video of a procedure that I did in one of the workshops. You can see so here you'll use something like a 6 or an 8 mm on the width of the lip, but most 6 to 8 mm will be fine. And then 30% density, 25 to 30 millijoule, doing 3 to 5 passes. People often ask, well, how long does it last for? Well, you get the initial swelling for a few days, but then often the effect will last certainly a few weeks. And I have seen several patients who will then have series of treatments and are very happy with the outcome. So this is immediately after treatment, and you can certainly see the plumping. And this can be a suitable treatment for those who are needle phobic or have hypersensitivity to some of the injectables, or simply just want for a short period of time just some fullness, but at the same time addressing some rejuvenation. So some other examples. Right. Now we're going to talk about one of my favorite handpieces, which is the 1940 non-ablative fractional laser. In fact, and this is very fitting, it's my colleague, Professor Peter Bjerring, who did most of the work on the 1940, and he was instrumental in its inception. This is Sharon, one of the first patients to have the 1940. You can see a very nice glow, clearance of the pigment, the skin is smooth. Here is another patient you can see from close up, very nice smooth skin with more radiance and loss of that epidermal pigment. And this is, as I mentioned, because of the more superficial effects of the 1940. And another close-up view where it's smoother, fresher looking and glowing. This can also be used on the back of the hands, the chest, the décolleté, you can see. And here is where you can also combine with the PR or the VL handpiece, depending on whether it's predominantly vascular or predominantly sunspots and sun damage. So you can do the IPL handpiece first, followed by the 1940. And you can see here in this patient who had sun damage, you can see definitely improvement and brightening of the neck area and the décolleté. And this is by using the 1940. And of course, you can also combine this with other treatments. This is a patient who lived in Florida with extensive photo damage and lentiginous and very thick leathery skin. And with series of the 1940, you can clearly see it's getting brighter, smoother. Patient is very happy. So for photo damage, for just this glow, this radiance, the superficial pigments, the non-ablative fractional laser 1940 works very well. You can also do a combination of treatments. So I have the privilege to have the PICO-A as well. And often I find that actually combining the two works very well. For some of the very well-defined lentigos, I like to treat them first with the zoom handpiece of the PICO-A. So that is the PICO-A, that is the picosecond laser of Candela, which has the best picosecond laser. So I like to then use the zoom handpiece for the standout lesions. And then I like to finish off by using the 1940 on the whole face. If you don't have the PICO-A, but you have the V-beam effective, for example, you can use that with a compression handpiece. Often I like to use some of the tightening devices for lifting and firming of the skin with the 1940. So the patient will get the tightening, but also the glow and the smoothness of the skin. You can combine that with skin boosters, for example. But what is also interesting is the cosmeceutical delivery by using the non-ablative fractional laser 1940, because we know from studies on a comparable wavelength, and that is the 1927, that we get this microscopic cracks in the epidermis and the channels of absorption. Essentially, there's more absorption of any topical that you apply on the skin following the use of this wavelength. And as part of an international split phase study where we combined cosmeceutical with fractional ablative, and we basically saw the synergism. So we could prove that there is definitely synergism between the two. But the purpose of the 1940 is this, where you see these microscopic channels, which means that when we apply something like, in this case, a triple antioxidant, there is 17 times higher absorption on the treated skin compared to the non-treated skin. So what does that mean? That means when we're using the non-ablative fractional laser 1940, the patient is going to get the benefit of that treatment. Radiant skin, healthier epidermis, glowing skin, but also we have the opportunity to add in the cosmeceuticals at the same time because they're going to be better absorbed, and therefore we have the synergism of the 1940 and the cosmeceuticals. There's just been a paper published by my colleague Konika Patel where they actually show up to 5 days there is still that microscopic clefting at the basement membrane, which means that up to 5 days there is enhanced absorption of cosmeceuticals topically. So this is a very good window where we can advise patients, for example, to use certain agents twice a day after the treatment for better effect. If you look at a patient like this with extensive photo damage, of course, this would be a perfect case for the 1940, but actually even better with the combination of the IPL handpiece followed by the non-ablative fractional laser 1940, which we call the light and bright. That is the term that we use when we're using the IPL with the 1550, but you can also use that with the 1940. So we can use the IPL first, followed immediately by the 1940, and then we can apply the cosmeceuticals on the skin, and the outcome is patients are very happy. If you look at a patient like this with melasma and a higher skin type, again, the vascular component can be treated with vascular lasers, and I'm sure Professor Bjerring is also going to allude to that. But also we can use the 1940 at low density with a 12 millimeter scanner width in combination with topical antioxidants and tranexamic acids, and that's how we can also have enhanced delivery of these molecules. In this case, and this in other case, can treat conditions such as melasma. Another case where by simply using the 1940 in combination with topical antioxidants and tranexamic acid, we can treat things like pigmentation and melasma. We can also treat the back of the hands. So here, for example, you can see just after one single treatment, very good improvement. Of course, you can also combine this with the IPL handpiece. So you can use an IPL handpiece first, followed immediately afterwards by the 1550 or the 1940, depending on what actually the main concern is, if it's predominantly just the roughness of the skin, or maybe even just some mild grade 1 actinic keratosis, where the 1940 has also the clearance for actinic keratosis in some countries. We can use that. What I have noticed using the non-ablative fractional laser 1940s is that you get repigmentation in scars. Scar colors improve. So in this case, there's a hypopigmented scar using the 1940, followed by prostaglandin analog drops, and you can see repigmentation, but also blending in of the scar in the surrounding tissue. This is something that is really very gratifying. Mild rhinophyma, you can use low-dose Accutane in combination with a vascular system, so that could be a pulse dye laser or the PR handpiece. And of course, you can also use the 1940 for just the surface improvement of the texture. Okay. If you look at this patient, this is an interesting case where the patient actually came to me for her jowls and the heaviness. I said, well, you're a facelift candidate, but she said, no, I don't want surgery. I want high intensity focused ultrasound. But at the same time, I offered her the 1940. And you can clearly see very good tightening and lifting effect from the focused ultrasound, but very nice smoothness of the surface of the skin by using the 1940. So it's just really about thinking laterally, where patients may actually come for one thing, but the 1940 can also have the advantage of offering that healthier, smoother, glowy skin on the surface. So with that, I have used my half an hour on with this presentation. I would like to thank you all for listening to me. And as I mentioned, we will have time at the end to answer questions. And now I would like to hand over to my mentor, Professor Peter Bjerring, for the IPL system. Peter, the floor is yours.
Thank you. Thank you very much for your kind introduction. I'm very happy to be here tonight and be able to talk about the Nordlys, which is basically my favorite device. I'm going to talk a little bit about the basics first, because many of you know about lasers with monochromatic light, one color, coherent and parallel light beam, very high quality light. On the opposite, we have the intense pulse light, which is a polychromatic with many colors. It's non-coherent and it's defocused. So we have to do something else in order to be able to use that kind of light to treat the skin. And what we do here is then we apply a filter after the light, before the light hits the skin surface. And choosing the right filters is actually crucial in order to get the desired treatment efficacy. So a bit of the history of the IPL devices first. The first IPL we saw was in 1992, which was called the photodome. And then through a lot of incremental improvements, we saw the Nordlys. And the Nordlys is now the device which is basically the most modern IPL in the world. So I'm very, very happy I've been on that journey together with the IPLs from the start until now. And I'm really, really impressed about the improvements that we have seen over these years. A little bit about the name, the Nordlys. Why is it called Nordlys? Actually, the Nordlys device is made in Denmark, where I come from. And Nordlys is a Danish word, which is actually meaning northern lights. And northern lights is what we also call aurora borealis, which can be seen in the countries to the north, and is actually a sort of electrical charged particles that glow in the night. So the Nordlys actually is a complete treatment system consisting of, first of all, the IPL, the 1550 nanometer fractional laser, the 1940 fractional lasers, the two ones we just heard this brilliant presentation about, and then the neodymium YAG laser, which is not the topic for today's talk. I'm going to talk about the IPL today, which is a unique narrowband IPL technology, which uses two different filters and sub-millisecond pulses for exceptional skin rejuvenation. So first of all, these different applications, meaning the different filters that we can use on this device, are CE marked for, first of all, epidermal pigment lesions, benign vascular lesions, telangiectasias, port wine stains, rosacea, point kiloderma of Sivat, inflammatory acne vulgaris, benign epidermal pigmented lesions, and permanent hair reduction as well. So these are the standard applicators. First of all, we have a dark hair removal applicator, which has a wavelength band from 645 nanometers up to 950 nanometers. Then we have the standard hair removal applicator for lighter skin types from 600 nanometers to 950 nanometers as well. Then we have the same again, but with a larger area for large area treatments again. Then we have a yellow applicator, yellow light, for vascular lesions of a little bit darker skin types, up to skin type 4. Having a wavelength band again delimited from 555 nanometers up to 950 nanometers. Then we have a skin rejuvenation and a vascular lesion device, which actually is meant for treatment of the lighter skin types, having a wavelength band of 530 nanometers up to 750 nanometers. And then The last standard one is the pigmented lesion applicator, which has a shorter wavelength band cut off at 400 nanometers, which is blue light, up to 720 nanometers, which is the first part of the infrared area. We have a couple of special applicators as well. First of all, the large area applicator for hair removal I talked about before, but also two very small applicators with a hexagonal applicator, which is much better to use at difficult to reach areas around the nose and eyes, for example. And again, there are some important factors that are important for this improved tissue effects that we see with the Nordlys. First of all, the selective wavebands technology. Also, we have short light pulses that are important. High optical energy is important, and also a large spot size. And I'll get back to why they are so important. First of all, the selective waveband technology. Many other IPLs, they only have one filter, which will filter off the shorter wavelengths down against the blue light. For example, this one up here, which has a cutoff at 500, about 50, but no filter to the higher range, meaning that it also delivers energy in a range from 1,000 up to 1,200, 1,300 nanometers, where the tissue water actually absorbs a lot of light. And that means that tissue water will be non-specifically heated, and that means that we need contact cooling of the surface in order not to reach too high temperatures of the epidermis at the same time. With the selective waveband technology in the Nordlys, we do have two filters, one filter filtering away the shorter wavelength, and one which will filter away the longer wavelengths that actually are absorbed by tissue water. That means that we don't get the non-specific heating of the tissue water, and we need much less energy to heat the chromophore that we are actually aiming at. In this case would be the reduced and the oxidized hemoglobin. So therefore, we get the same efficacy with much lower energies because we are much more selective here. Let's look at the shorter light pulses. Different light pulses are important because for the very small targets, we need a short pulse in order not to have the heat to spread to the surroundings during the pulse duration. Therefore, we use only short pulses for very small targets. For larger targets, as we can see here in the port wine stains, for example, we would use longer pulse durations around 8-10 milliseconds. And again, with the deeper the red and the bluish angiomas, we need a long pulse duration in order to deliver enough heat to these larger structures. And therefore, we are able to tailor the pulse duration exactly to the vascularity that we are actually going to treat. So pulse duration is really important. We can have either a continuous long pulse, or we can split up the pulse in smaller pulses in between, so that we can actually target small chromophores and having a cooling effect in between and then hit it again. Exactly as we see with pulse dye lasers, where the actual pulse duration is 0.45 milliseconds, and longer pulses are only made by stacking these pulses one after each other. And if we look at the high optical energy, it's really important that we can deliver enough energy to coagulate the vessels. This is just one after one from Dr. Cartier in France. And as you can see in the center of this ellipse, you have a very fine reaction, meaning that we can deliver enough energy in just one treatment to treat these vessels. Also, the large spot size is important because as soon as the light hits the skin surface, we will get a spreading of the light, a diffusion of the light, because the light will hit the different structures in the skin and will be reflected off the beaten path. so they will go in other directions. And that means that a lot of the actual beam intensity will be eaten away by this spreading of the light. And if you have a very narrow spot size, you will very soon get all of the light diffused or spread, which is not happening with the larger spot sizes. So you will get deeper effect with the larger spot size compared to the smaller spot size, even if you're using exactly the same other treatment parameters, the energy and the pulse duration. So large spot sizes are important to reach deeper lesions. And again, with this selective wavebands technology and the different filters in the different handpieces, we can actually treat acne, we can do hair management even in darker skin types, vascular lesions, pigmented lesions, non-pigmented benign lesions as well, and photorejuvenation. And let's have a look at acne first. This is a picture from Professor Agneta Turelius from Sweden. And this is after the treatment. As you can see here, very, very good effect, both on the actually skin structure, the scarring, and also on the inflammatory lesions. Another picture here, also reducing the inflammatory lesions and also smoothening the skin texture at the same time. For other kinds of vascular lesions, for example, telangiectasias, port wine stains, rosacea, and poikiloderma civet, we also can use these different applications. We do have two PI applicators, the standard PI applicator and the small one, the hexagonal one, and we have the yellow applicator, the VL555, and the small one as well here with the hexagonal spot. And these are actually comparing very, very well to the pulse dye laser, which was the gold standard before we got the IPL. Normally, we would use the yellow dye, as can be seen on the diagram to the left, giving a wavelength band centering around 595 nanometers. That is the pulse dye laser, and actually the VL applicator of the IPL here has about the same biological effect. If you compare a pulse dye laser and the IPL, in this study from 2020, we had a retrospective analysis for facial telangiectasias using both the pulse dye and the intense pulse light. And what we got out of that was the conclusion was that pulse dye laser and IPL with a vascular filter had similar clinical efficacy. Another study here, which actually looked at the IPL, and in a split phase study, we could see that the intense pulse light and the pulse dye laser were equally effective in reducing facial erythema. And again, these are the different types of vascular manifestations that we would normally treat with the IPL. And as Professor Al-Niaimi showed before, we will often combine the IPL with the fractional lasers 1550 and 1940 as well. So combinations are good. This is again a single treatment with an IPL, and you can see how effective it really is just after one treatment. This is another one here. Again, 2 IPL treatments, nearly normalized skin color after 2 treatments of this vascular malformation. Another one here, which has quite a deep component as well. It needed 3 treatments to get to this treatment. And you can still see a little bit of the vascular malformation inside behind the hairline that has not been treated in order not to reduce hair growth at the same time. This also has a deeper component, which means that we need to treat more times, because we will always treat from the surface, because the upper vessels will make a sort of shadow, so we cannot reach the deeper vessels in the same treatment. So you have to reduce them in the first treatments in order to be able to treat the deeper vessels afterwards. So this one here required 6 IPL treatments to get this result. Again, the same here. There are difficult ones, actually really difficult to treat, because these actually has both a deep and a superficial component. 8 treatments were required here. This one, 5 IPL treatments again. And that is Asian skin, and Asian skin is actually much more difficult to treat than Caucasian skin. Another one here in Asian skin, very nice result after 5 IPL treatments only. Again, a very hypertrophic capillary malformation here on the back. 5 treatments again, and you can see a very high intensity has been needed to treat that, and you get a little bit of epidermal hypopigmentation as well, which is a sort of necessary side effect to reach this result. If you look at the nose here, we can actually see the reduction here. This is a treatment of rosacea. 3 treatments of the IPL again. Another one here with larger vessels, meaning longer pulse durations and higher fluencies as well. One of my own patients here, 3 IPL treatments, 2 IPL treatments of this one here. And this is from my colleague Michael Drossner in Germany. This is a hemangioma. And I know that a lot of these hemangiomas will regress spontaneously, but treating them with IPL will actually accelerate the reduction of these lesions here. Again, another one here, a hemangioma can also be treated. 7 treatments. This is one of my rosacea patients treated, which is really important to see that it actually not only reduces the existing inflammation, it also reduces the permanent vascular dilatations. So we get the immediate inflammation reduced and also the permanent damages from previous inflammations. This is a difficult treatment. This is a patient, a young boy with ulcerothema ophrioideus, which is a variant of keratosis pilaris. This is really difficult to treat, but after 3 IPL treatments, this is result. Actually, I don't see these kind of results all the time in this disease, because we often get some recurrences. Another one here from Japan, Asian skin as well, which is difficult, even with the PR 530 nanometer. Sorry, going back to this one, here we are. This is another rosacea treatment in Asian skin. Again, diffuse redness. And here we have a deeper lesion. This is a venous lake, where we are using a very long pulse duration of about 30 to 40 milliseconds, which will then actually perform a much deeper treatment, which is necessary here. This is a chronic radiation dermatitis after radiation therapy, and we see these as a late side effects after radiation therapy. They can easily be treated. A lot of people would think this is atrophic skin, which might be dangerous to treat, but actually we normally don't see any side effects after treating with the IPL. Scar treatment is important as well. Red scars can easily be treated with the IPL. After that, we would sometimes treat with the 1550 fractional laser to reduce the volume of the scar as well. But often we treat with, in the same session as also Professor Al-Niaimi told you about before. So you can do the IPL treatment first and then the other one. This treatment is a treatment of a bruising after a filler injection. And you can actually reduce this bruising immediately when you're treating it. So if you have this bruising reaction, the patient comes back the next day, just treat it with the IPL, and it will very, very soon regress. Otherwise, it will last at least 2 weeks to get rid of that. And again, let's move on. Another bruising here. You can see how it actually works very, very well in this kind of indication. Now let's move on to photorejuvenation. Photorejuvenation is a very interesting concept because With the IPL, the mode of action is that we are applying a short pulse duration yellow light, which is absorbed by the capillaries. Then the capillaries, because of the heat, will dilate a bit. And that dilatation makes fenestrations in the walls of the capillaries, and thrombocytes or platelets will leak out from the vessel into the interstitium where the fibroblasts are located. And the fibroblast will then think that there is a big lesion, because normally thrombocytes are not present outside the vessels. And when they're there, they will release a lot of growth factors that will stimulate fibroblasts for making more collagen and elastin and hyaluronic acid. That is the basic of the photorejuvenation of the collagen new formation. Photorejuvenation also implies reduction of photo damage from vessels, enlarged vessels, and pigmentation, mottled pigmentation, for example. So photorejuvenation will actually imply three different components: the pigment, the vasculature, and the collagen. And again here, in this study, a comparison between the non-ablative laser and IPL. And both IPL and long pulse dye lasers are effective for facial skin rejuvenation, even in Asian skin, which is difficult skin to treat. And this is a photorejuvenation where you can actually see the efficacy of the IPL-2 treatments, especially here on the pigmental part of the rejuvenation process, but also on the fine texture and the fine wrinkles. 2 treatments only. This is a lower eyelid bag. As you can see, this very, very fine contraction of the skin in this area. And again, if you look at the skin texture here inside the elliptical area, you can see how the skin structure has improved after a single treatment here. In this treatment here, if you look at the lower eyelid first on the left side before, and then on the right side, the left side first, then the middle is after 3 months after a single treatment, and the right-hand side is at 6 months after a single treatment. And that actually shows that it is a prolonged effect of these thrombocytes that are slowly dissolving in the skin. So what we have here is actually the conclusion. The Nordlys IPL, with this selective waveband technology, is a highly versatile and economically efficient device. It is designed to address a wide range of medical and cosmetic vascular indications. And thank you very much.
Thank you, Professor Bjerring. This was excellent, as always, and very informative. Thank you so much. Well, the good news is we have plenty of time, really, for questions and answers. So, and I certainly have a few questions for you, Peter. But there are already a few questions from the attendees. So the first one actually is for you, Peter. So does the use, basically using the selective waveband technology, where you explained very nicely that it's a narrow band of filter of IPL without the filtering at the longer wavelengths that are absorbed by water. What about stacking using low fluence with a narrow band? If we stack, will we get a similar effect to, for example, a broadband IPL? Maybe you can explain that.
What happens if you are stacking? It depends on how close the pulses are after each other. If you do one pulse and let the tissue cool again, and actually it doesn't need so much cooling, because with the selective waveband technology, we don't use these high energies as we did before we got that. And then it will not change very much. But if you apply the pulses very close to each other, you will increase the let's say the non-specific heating. So if I do stacking, I wait a bit before I do the next pulse in order to actually double the effect of the treatment, but not heating non-specifically.
Okay, that's very nice. And may I ask, since we're talking about this, how you nicely explain that you get dilatation of the capillaries as a result of the heat, and therefore you have the fenestration, the leakage of the thrombocytes, and the release of the growth factors. Is that pulse duration dependent? Is that why the setting is 2.5 millisecond double pulse rather than a single short pulse?
Actually, it is, because if you are using longer pulses, much of the heat will then be conducted by tissue conduction to other structures outside the vessel, because the capillaries, they are small. And that means that we need to confine the heat within these capillaries without heating the interstitium around it. We do two treatments, two pulses with 10 milliseconds delay. That actually allows the capillary to cool down in between the two pulses.
Okay, this is very interesting. And actually it reminds me of the work from Brian Zellickson and Eric Bernstein, who used the 10 milliseconds on the pulse dilator and showed similar results. Reduction in solar elastosis, increased collagen, Gren zone, the basement membrane, and I seem to recall that their explanation was very similar, that using the 10 millisecond pulse duration led to vasodilatation, edema at the papillary dermis, and that is how we then have the thrombocytes fenestrating out of the capillaries and releasing the growth factors. So very interesting.
Yes.
The next question is actually probably for me, because it's a very good question, and that is the parameters for higher skin types with acne scars. Okay, so there are a few things to consider here. First of all, the risk of post-inflammatory hyperpigmentation. I assume that is why the question is asked. So if we talk about the fluence, that is going to give us the depth of penetration. So that is pretty much a variable that will not massively be affected, because if you have a very deep scar, you still need the high fluence to get to the base of the scar. So what you're going to play with is two things: the density, which you can reduce the density to reduce the risk of post-inflammatory hyperpigmentation. And the second thing, which is really unique to the Nordlys, is reduce the pulse duration. So this is going to be an expert mode. So what I do is I go on the 1550, go on the expert mode. So you can choose, for example, acne scars, which will give you something like a 45 or a 47 millijoules, so quite high, getting into the depth, and you can see it's around 700 micron deep. Then I go into the expert mode. Then I shorten the pulse duration. So initially it will give you a pulse duration of 2.7 milliseconds, so I can go down to 1.5 or even 1 millisecond. And then you see the width of the coagulation column is going to be narrower. And then you can just compensate by increasing the fluence a bit, because it's going to then give you the fluence per coagulation column millijoule, and it's going to give you the depth of penetration. As long as you reach the same depth of penetration, between 6 to 750 micron, that will be sufficient for these acne scars. But the trick is to shorten the pulse duration, so you narrow the coagulation columns. Then I go to 20% density, do a few passes with cooling in between, so that is extra cooling in between. And then I just increase the intervals between treatments. So typically, if it's in a lighter skin type, 4 to 6 weeks, I might just do 6 to 8 weeks. In a higher skin type, and I will put them on a non-hydroquinone lightening agent. That way, you can try and minimize the risk of post-inflammatory hyperpigmentation. Now, I have done many cases on higher skin types, skin types 5, and I have had very low numbers of post-inflammatory hyperpigmentation. So reduce the density, go on the expert mode, shorten the pulse duration, compensate for the depth penetration, cool in between, and then add in a topical agent in between and use longer intervals. But Peter, I'm interested to hear whether there's anything else you would like to add on this particular topic.
I have a question to you, and for you, Will, it's about, I know you are a very skilled Mohs surgeon as well. You do a lot of surgery, and I would like to know, do you use any laser here of these kinds to prevent scars, not to treat them, but prevent them immediately after the surgery?
Well, I mean, so I haven't done the work that our Danish colleague did, which is Merete Hedersdal, where she actually pre-treated prior to the Mohs. That was a very elegant study that she did. So prior to actually making the incision, she would treat, or she would treat immediately after tumor extirpation. So you essentially have a wound. So that I haven't done. But yes, I do frequently do early laser treatments as soon as the sutures are removed. So by day 10 or 2 weeks, yes. So often patients will come and say, I want the best scar. What can you do? So obviously part of it is reduction of the tension, good surgery, good suturing. But then I will say to them, in addition to using the silicone gels, we can start with the 1550 very early on. I like to combine that with a pulse dye laser because there's enough data on the pulse dye laser. But again, this will be a question to you, Peter, whether you think using the PR handpiece, will give us similar changes in the collagen and prevention of the scar. But the way I do it, and that is also because I have access to the pulse dye laser, which is the V-beam, so I will do a low fluence pass with the pulse dye laser, with the V-beam, and then low density, relative low fluence, so 25 to 35 millijoule, depending on the scar and the skin type, with the 1550. So yes, it definitely does work, and it reduces the risk of scarring. But again, my question to you is, I use a lot of pulse dye laser for fresh scars because of the evidence behind it. Do you think I can get the same result, not just with the erythema, but also prevention of hypertrophic scars if I use just the PR handpiece?
I'm using that regularly. I have a V-beam as well, so I could use it as you do. And I know the literature says that it has a fantastic, but I use the IPL mostly. I use the PR applicator and I use short pulses, and I think I get the same results. And another thing is, it's easier to delegate IPL treatments than to delegate pulse dye laser treatments. So my nurses are more confident using IPL than using the pulse dye laser, which also means that in a busy clinic, we can do more treatments if we employ the IPL for this.
Absolutely. I mean, I was at a conference in Stockholm a few months ago, and I spoke to Agneta, who you know very well from Sweden. And she does the same, and she also has a lot of experience using the PR handpiece for the scar. So I think for the audience, that's very interesting to know that you can also use the PR handpiece for the scar. Now, I have a few questions for you because I'm also using this opportunity to ask. You actually published a very nice study on the port wine stain, so the pulse dye laser resistant port wine stains. So these are port wine stains that were treated with a pulse dye laser, which, as we know, is the gold standard, often seen as the gold standard for port wine stains. But those patients who then stopped responding, you then treated them with the Nordlys IPL, and almost 50% further reduction in discoloration and improvements. And it's a very nice study from, I think, 2006.
Yes.
So maybe you could just expand a little bit on that.
I can, yes. And you're right. It was 49% that got either a good or a very good result after being stuck with no more improvement after pulse dye laser treatment. Then we treated with the IPL. And what I think is the reason for the efficacy here is the larger spot size. We have a spot size of 48 millimeters by 10 millimeters, which is really large compared to pulse dye laser, where we actually get a much better penetration. As I showed you, larger spot sizes will give better penetration. I think that might be the reason for the success of this treatment.
I certainly think the large spot size gives us better penetration, but I also think the bands of different wavelengths are probably also targeting different sizes of vessels.
That's true.
There are a few more questions. There are actually a few more questions that have now appeared, which is great. So one of them is back to the scars using the PR handpiece. What is the endpoint for these vascular scars? Is the endpoint purpura? And in that case, are you going to use a short pulsation?
Actually, what my endpoint is a temporary bluish discoloration which disappears again after a few seconds. And that means that you use a relatively short pulse duration, 3 milliseconds, for example, and that will produce this bluish discoloration, which is not a purpura, which is not permanent purpura, but just shows us that we get this heating of the vessels, and we get this conversion of the hemoglobin into methemoglobin.
And we're not talking about diffuse redness here. We're talking about red scars. That's still
Yes,
the endpoint that you want,
definitely,
right?
Yes. And that actually works for me. Go on, please.
Yeah, sorry, please.
You please go.
Okay. No, I mean, I wanted to ask, when would you actually want to see purpura with the Nordlys, with the exception of port wine stain? Is there any other condition where you actually want to see purpura?
Only venous lakes, for example.
Okay.
But no, but otherwise, it's not really necessary to do it. You will still get a very good effect. Before, we would think that we needed purpura to get the efficacy of the treatment. It's not necessary now.
I agree.
With this much better filtering system that we have in this selective wavelength technology, we do get equal results with no purpura.
I totally agree. I think where it comes from, Peter, is that the first IPL, as you mentioned, didn't have the square pulse shape. So they had the peak followed by the tail, and patients would often get purpura or required purpura for getting better results. And that's how the literature started. And that then was passed on to the next generation with the thinking that you need the purpura. But I totally agree with you. I get phenomenal results without the purpura. I do seek purpura when it's port wine stain, but for diffuse redness, for poikiloderma, you don't need purpura.
Yeah.
Staying with the Nordlys, actually, there are many, staying with the IPL, there are many questions on the IPL. There's a question about acne. Basically, do you use a single pulse or a double pulse? And if so, when would you choose what?
Actually, I use the photo rejuvenation pulse, which is 2.5 milliseconds, then an interval of 10 milliseconds, and then another pulse of 2.5 milliseconds. That actually works very well. It's not very painful, and as you know, teenagers, they don't stand pain very well. So therefore, in acne patients, this is an important factor, as well as you can treat the patients without very much pain. And that pulse duration.
Yeah. Would a single short pulse still work? Imagine if someone had anesthesia, for example. Would it still work?
It works, yes, definitely, it works. I don't know if it works the same, because I've been using this double pulsing for so many years now that I actually forgot that I could use a single pulse as well. But if you are using a single pulse, it will hurt more.
Yes, for sure it will hurt more, I agree. Now, staying on acne, because many colleagues ask me about it, especially when I do training, and they will say, well, there is this mode on PDT acne, where is that from? And I know that's actually from yourself, because you were one of the first to essentially incorporate that when it was still a very Danish device. Do you think there's any way of using PDT with the millisecond short pulse durations of the IPL rather than the traditional minutes exposure to LED light? Will it still work in a similar fashion, do you think?
It does. It doesn't seem that you need a long duration. You just need the photons. And actually, I treated a lot of basal cell carcinomas in Gorlin's syndrome patient with this, because then they can have 50 or 60 basal cell carcinomas. And I just used the IPL. I used the PR applicator, because that would cover most of the Q bands of the protoporphyrin 9 absorption peaks. And I got a fantastic result of that. So you can do even cancer treatment.
I have seen your talks on that, and I know that in Scandinavia PDT is used often, and that is, I think, it's important, because the traditional thinking is that you need the duration in minutes of exposure to blue or red light, but you can still achieve that with a millisecond exposure with the IPL, correct?
That's correct. You just need the energy, and around 8 joules seem to be enough to treat with PDT. That would actually activate most of the borderline present.
At 8 joules double pulse?
Yes.
Okay. Well, I think in terms of, for the sake of the time, we can perhaps take one more question. We'll just go to, because some of the questions were already explained. Could you please explain the changing? Okay, so it's a question to me. Can I explain again about changing the pulse duration in the 1550? Okay, I'm going to explain that one more time. When we study about fractional laser technology and the relationship of the depth with the fluence, that is what we study, and that is the depth of penetration of the coagulation column is proportionate to the fluence. In other words, the higher the fluence, the deeper the coagulation column of the non-ablative fractional laser is. So that we understand. But one of the things that we discuss less about is the width of the coagulation column, because that is important. And the width of the coagulation column is also partly related to the pulse duration. So you have the pulse time. If you have a longer pulse duration, you're going to end up with a wider coagulation column. If you have a shorter pulse duration, you'll have a narrower coagulation column. That becomes important when you are dealing with the density and the risk of post-inflammatory hyperpigmentation, because many of the studies have consistently shown that in higher skin types, the risk of post-inflammatory hyperpigmentation increases with a higher density. So if you're using a high density, the risk of post-inflammatory hyperpigmentation increases. So the density is not just the density of the columns per centimeter square, but it's also how wide they are, because the wider coagulation column is, obviously the closer they potentially can get to each other and the more bulk heating you have, with a higher risk of post-inflammatory hyperpigmentation. So with the Nordlys, with the 1550 in the expert modes, you actually, when you click on expert modes and you see the pulse time, in most cases it's 2.7 milliseconds, you can reduce that. So you go to the dial down and you reduce the pulse duration below 2 milliseconds. And then if you look below at the estimated width of the coagulation column, because it will show it then, once you click on the expert mode, you will see that when you reduce the pulse duration, the coagulation column's width is becoming narrower. So then that, together with reducing the density down to, for example, 20%, means that per treatment, per pass, you have fewer coagulation column, but also thinner coagulation column, which means you have a little bit more space in between these columns, so a lower risk of post-inflammatory hyperpigmentation, because the depth is not affected. The depth, you still have the depth by the fluids. So that to me is really a very, very clever thing, where you can actually change the pulse duration, meaning you can choose a narrow risk of PIH. But Peter, I would love to hear your insights into this, because I know you were also instrumental in a lot of the engineering of the non-ablative fractional laser. Do you have anything to add on to what I was explaining about the pulse duration and the coagulation column with either the 1550, particularly it's applicable to the 1550, but anything else you want to add maybe also on the 1940?
Around the 1550, I think it's interesting that we get these very narrow coagulation zones that are actually very well suited in a low density to apply laser-assisted drug delivery system. You mentioned that before, and I think it deserves to be mentioned again, because with these settings, we can actually get a lot of larger molecules through the skin barrier, which would never be possible without making this treatment before. And that,
okay, you're talking about the 1550?
Yes, Also, not only the 1940, but also because we don't need ablation. We need coagulation, because a coagulated column will work as a sponge, which will actually absorb the drug or the cosmeceuticals that you apply on the surface and keep it as a sort of reservoir, which is slowly delivered over time, better than a hole.
Absolutely. And you know, you're spot on there, because if you look, for example, even on a 1 millisecond, and I have studied this on the 1550, even when you go down to the 1 millisecond, I think it's about 270 micron wide. And if we look at many of the molecules that we want to get into the skin, anywhere from 80 to 150 micron. So it's perfectly going to fit into that coagulated column. So this is something that, thank you so much for that, because I completely overlooked the drug delivery with the 1550 using a short pulse duration, and it would be also much less painful. I can tell you
exactly.
when you use
the 1940 is more than the 1550. No doubt about that.
Absolutely. Especially when you go on a 1 millisecond, it's becoming much less painful, less downtime. But that would be great then for the drug delivery. So
yes,
thank you for that. Now, with that, I think we have had a very good discussion. We managed to answer many questions. So, Peter, thank you so much.
Thank you.
Thanks a lot. I would like also to thank the audience, really, for their participation, for their attention, for listening.